Hello, welcome now to the new seminar, in hospital seminar number 8, that will be about emergencies during labor. This is a topic that is not very common. These are some kind of emergencies, particular emergencies that we will see that can occur during all the process of labor. They are not very common, but it's very important to know how to recognize them and how to be able to diagnose fast and act fast. There are some maneuvers that I'm going to show you with a little of videos in order to learn how to manage these situations and also be able to ask for help and to don't desperate. So first, only to show you the objectives of the class, we will talk a little about the understanding of the mechanism of the delivery. It's very important to know the stages of the delivery, what happened during the delivery, because after that, if we know that, we will be able to diagnose all the different emergencies that can occur during the delivery. Also, we can understand the causes of the emergencies and how to manage them in an easier way. Then we will see one by one different emergencies during the delivery. There will be shoulder dystocia, stopped second stage, cord prolapse, uterine inversion, and podalic delivery. All of these emergencies are not all the emergencies that can occur during the delivery. Of course, there are a lot of more emergencies and more common, for example, preeclampsia, eclampsia, or PPH, that are the most common and most mortality associated emergencies. But as that topics are very important, we will see it in one particular class for each topic. But these topics, that are a lot of different small topics, we will see it together only in this presentation. So to understand the mechanism of delivery, it's very important to know how is the pelvic bone. Because the pelvic bone is the channel where the baby is going to pass through in the moment of the delivery. And the pelvic bone, it's have two parts. The inlet part, that is the upper part, and the outlet part, that we will see in another photo. And what is the particular part of this? Is that both of these parts, the inlet and the outlet, are not like a perfect circle. They have an ovoid form, like this. So they have one longer axis and one shorter axis. In a perfect circle, we have the same longer and shorter axis. But in this situation, in the pelvic bone, we will have a longer axis and a shorter axis. And the same happens with the head. The head of the baby have a shorter axis, that is the biparietal diameter, that comes from one parietal bone to another, that is in average from 10 to 10.5 centimeters, and the fronto-occipital axis, that is the longer axis, that is between 11 and 13 centimeters. This is very important. Why? Because in the inlet that we have here, the anteroposterior diameter is 11. Okay? So here, this diameter is 11. The transverse diameter in the inlet, that is this, is 13. What means that the ovoid in the inlet is in this orientation. But in the outlet, the ovoid is in this orientation. So the baby must rotate in order to trespass the pelvic bone and go outside the mother through the perineum. So here we have a representation of the pelvic bone. Here we can see the inlet and the outlet. As we can look here, the inlet, yes, is this one, and the outlet is from here. The limiting bones in the inlet, the hard prominence that limitate the axis in the inlet, are the sacral tuberosity and the pubic bone. So here, this is the most little diameter. So the biparietal diameter of the head of the baby must be like this. So the baby must pass this cavity looking there with the eyes or looking there, okay? But the eyes cannot be looking back or looking forward. But when the baby go in the pelvic excavation, the little diameter is not anteroposterior, is lateral diameter between the spines. Here we have if you can see, the ischiatic spine, and in this side we cannot see, but there is also another ischiatic spine. Both of these spines make the interspinous diameter, that is a very little diameter. That diameter now is the little diameter of the inferior or the outlet part of the pelvis. So the baby must rotate in order to put the biparietal diameter that was in this orientation in the entrance of the pelvis and put the biparietal diameter in this orientation in the outlet of the pelvis. Maybe you're a little confused about this, but it's very easy. I will show you with a video after this. So now that we know the mechanism of the delivery, we will review the normal SVD, because we need to know the temporality of a normal FDD, to know the stages of a normal FDD and the normal time of every stage in order to be able to diagnose when some stage is taking more time than the normal. So here is a line that represents the delivery process, the labor process. So the labor have different stages that we will see. The labor starts from the mother that is pregnant. The labor starts here with uterine dynamic and cervical modifications. Here I made a mistake. I have to raise that C. So when the mother starts with the uterine dynamics and cervical modifications, if you make a VE and you check that there is some effacement or a little bit of dilatation, we can diagnose that the labor have started. That means onset of labor. That the normal is to start after 37 weeks. If it starts before, it's onset of preterm labor. That is a pathology. And the end of labor, of all the process of labor, is with the placental expulsion. So this is the last stage, the placental expulsion. When the placenta is away of the mother, we finish the process of labor and start the process of puerperium, the puerperium. So all this process of labor can be divided in a lot of different stages that we need to know. First, the first stage is the dilatation. The dilatation stage is when the onset on labor starts until the complete dilatation, that is 10 centimeters. And the dilatation stage is divided in latent phase of labor, that is represented here, and active phase of labor, that is represented here. Latent phase of labor is between the onset of labor and until the mother reaches 4 centimeters. That is when you can put 2 fingers completely inside the cervix, here in this part, when you do the VE. And the active phase of labor is between the 4 centimeters and the complete dilatation, that is 10 centimeters. That is when you can open your fingers and palpate here completely, 10 centimeters. And you cannot feel rest of cervix, neither in the posterior part, in the lateral or anterior part. After the active phase of labor, we have the second stage. That is the stage between the 10 centimeters of dilatation until the fetal expulsion. That is when the baby delivers. So here we have the baby outside the mother. Between the 10 centimeters and the fetal expulsion, we have the second stage. And the third stage of the labor is between the fetal expulsion and the placental expulsion. Each one of these stages conform the process of labor. And each one of these stages has his own normal timing and is a natural, normal process. But sometimes we have situations that can make these stages come longer, and we can have different problems during each stage. So we will see all the different emergencies that can occur in any one of these stages. So here we have the stages, and now we are going to review the normal timing. The dilatation, the normal timing is from 20 hours. It can last at 20 hours in a primigravida or 14 hours in a multipara. That is the normal duration, the limit. And the active phase of labor can last in a primigravida with a velocity of 1.2 centimeters per hour and in a multiparia 1.6 centimeters per hour. That is the normal limit. If a primigravida is in active phase of labor with 5 centimeters and you make a VE after 2 hours and she continues in 5 or she is in 1 centimeter, that means that it's not progressing in the normal way because she's not fulfilling the 1.2 centimeters per hour. That means that we have a stopped active phase of labor or slow active phase of labor. And here in Bagari you use the word obstructed labor. The normal duration for the second stage in a primigravida is to last 2 hours. That is the maximum. So we have time in a primigravida since the complete dilatation occurs until the baby goes out, we have 2 hours. In a multipara, we have 1 hour because this process goes a little faster. So that is the normal duration. But if we have spinal anesthesia, this can increase 1 complete hour. So it means that the maximum in a primigravida that is under spinal anesthesia is 3 hours, and in a multipara, 2 hours. But here in Bagadi, we don't need to know this because we know that in Bagadi we don't have anesthesia. This is only for you to know because maybe in the future the government will provide spinal anesthesia. I think it will be not very soon, but it will happen. So we need to know. The third stage is from the birth of the baby, so from here, until the placenta delivery. That is the end of the labor. After the placenta delivery, we know that is the puerperium process. So this stage, the third stage, may last at the maximum of 30 minutes in a multipara and 40-45 minutes in a primigravida. But it's very uncommon to have this. The most common is to have a duration of 5 minutes, 10 minutes as a maximum. But it's important to know because maybe some mothers can take more time than the normal. So now, in our objective, we have seen how to understand the mechanism of the delivery, and we will see now what is a shoulder dystocia. That is the first emergency that we will see. A shoulder dystocia or shoulder retention is the impactation of the anterior shoulder against the pubic bone. Here we have the anterior shoulder of the baby. It's an impactation against the pubic bone. Here we have a problem of space, a conflict of space, and the fetus cannot go out because of the impactation of the shoulder. The diagnosis of this emergency is when the fetus head is out and the body doesn't come out. And we have been waiting a little of time and everything, but the body doesn't come out. Some people define it like after 1 minute of the delivery of the head and the body doesn't go out, it means that we can diagnose this disease, but I think that is a not very good definition because we need to act before 1 minute. So it's better to diagnose only when after the immediate delivery of the head, the shoulder doesn't go out, you have to start with the actions. The prevalence of this pathology is 1 in 750 deliveries. This is the global prevalence, but here in Kenya I think it's less than this because the babies weight not too much and we have a not too much macrosomy. Most of the time it's unexpected. Maybe there are a lot of different risk factors that I'm going to show you, but most of the time you cannot expect, and it's only because the mother have a very narrow pelvis, or maybe this baby have a very big shoulder and bone prominence. So maybe the patient cannot have any risk factor and you can have this problem, so you need to be aware of that. So the risk factor, important risk factor here is the estimated fetal weight more than 4,000 grams, because that means macrosomy, and that babies have bigger body, bigger head, and bigger also shoulders. This mnemotechnic can help you, that is called DOPE, DOPE. That means diabetes, obesity, post-term, post-maturity, because they grow a little more, and excess of weight gain during the pregnancy. So here we have a mnemotechnic called alarmer. In my country, in Chile, the prevalence of gestational diabetes is very high, so we have very big babies, and this complication is a little bit more frequent. So we, in our medicine school, they taught to us this mnemotechnic tool that will help us, that is called alarmer. Ask for help is the first thing that you have to do. Then a lot of different maneuvers in order of importance that you have to do. So the first one is the most important, then a few little important, and the last one is the less important maneuver. We will see one of them one by one, and I will explain a little bit about them. So the first maneuver, after asking for help, that is the most important thing, is to lift 2 legs. When you lift 2 legs, you increase the anteroposterior diameter for the baby to pass. So this maneuver is called the McRoberts maneuver. It's not important for you to know the name of any maneuver, but you have to memorize and understand the concept of the maneuver because that is the thing that you have to do when you are in front of this complication. So it's flexion and abduction of hips. Now we will see a video about this. So here we will see a video about the McRoberts maneuver. The McRoberts maneuver, you ask for help for 2 different persons that each one of them cut 1 leg of the patient and help you with flexion and abduction. in order to help the shoulder to desimpactate. So here you will see the shoulder of the baby desimpactating from the pelvis, helping you for the extraction of the fetus. See here? Now the shoulder is desimpactated. That is the most important maneuver. If I have to choose only one to remember, is this maneuver. After the L of leg to legs, we come again to an A, the second A from alarmer, that is anterior shoulder desimpactation. Here we can see the Rubin maneuver and the Masanti maneuver. The Rubin maneuver means inverted wood screw maneuver that we will see in a video. The practitioner apply pressure to the posterior surface of the posterior shoulder, adducing the shoulder and rotating the fetus 180 degrees to deliver that shoulder anteriorly. And the Masanti maneuver, it's only to make external compression a little bit up of the symphysis in order to decompress the shoulder and move it a little bit posterior to decompress the shoulder of the baby against the symphysis. Here we will see a bit of the Wood maneuver, the Rubin maneuver, sorry. So here, in the baby, when it's in the cavity, we have the anterior shoulder that is here and the posterior shoulder. This is the anterior shoulder because it's in the anterior part of the mother, and this is the posterior shoulder only because it's in the posterior part of the mother. So now we have this shoulder dystocia, and the operator put the hand in the posterior aspect of the posterior shoulder in order to rotate the baby. When the operator rotates the baby, the shoulder that was here now is out of the mother, so you can pull the baby out. Now, the R, that is rotation of the posterior shoulder, that is the fourth part of the alarmer, is called the Wood maneuver. You don't have to remember the name again. The only important thing is to remember the concept. Now you do the opposite than the first maneuver. So you put your hand in the anterior aspect of the posterior shoulder in order to rotate the baby in the other sense, in the other way, anti-clock, and you can decompress the shoulder because you put the shoulder that was anteriorly, you put it posteriorly. Here we have a video.
跟住就係short dystocia 入邊嘅 wood screw maneuver 啦。咁我哋咧呢個時候咧，頭先我哋係做緊嗰個 Robin 2噶嘛，所以就 keep the original hand in the posterior aspect of the anterior shoulder 先，跟住就 insert the other hand 啦 from the posterior side of the vagina 啦 ，and touch the anterior aspect 下邊呢度 anterior aspect of posterior shoulder 啦，就 push the anterior shoulder forward and attempt to rotate the fetus for 180 degree to mother's right 啦，呢個 condition 就係啦，咁又係啦。如果個 shoulder is released 嘅話咧，咁我哋就 apply downward traction 嘅。咁我順便講埋個叫 reverse wood screw 啦。咁譬如如果頭先呢個係 fail 咗咯喎，唔得嘅喎，咁樣咧，我咧就 remove 呢隻手啦 ，remove 我嘅 left hand 啦。咁個 right hand 咧就係 move from the posterior aspect of anterior shoulder down to the posterior aspect of the posterior shoulder 啦。咁跟住咧就係又係咁樣啦 ，push forward and try to rotate the fetus for 180 degree in an opposite direction 咯。咁如果得嘅話，中到個又係出啦。
Okay. That video was a little bit longer with a little of a difficult to understand the English, but I hope that it was useful for you. Then the M, that is the fifth letter from the alarmer, that is manual removal of the posterior arm. If all the things that you have done previously doesn't work, you have to do this maneuver. That is only to introduce your hand in the posterior part of the baby, in the posterior shoulder, and try to catch the arm and pull it away. So now we're going to see another video.
OK， 咁而家就到 shoulder dystocia 入邊嘅 removing the posterior arm 啦。首先咧，我哋 place the hand in the vagina and trace the humerus of the posterior fetal arm from the shoulder to the elbow 嘅。咁跟住咧，我哋就 grab 啦 and gently sweep the forearm across the fetal chest。跟住 the hand is pulled out 啦。如果個 forearm is not accessible 嘅話咧 ，pressure can be placed to the antecubital fossa。咁我哋就即係簡單嚟講係 flash the elbow 啦，就 reach the forearm 啦。咁跟住亦都係啦 over the chest 咁就出咗隻手啦，係啦。咁佢就會自己 BB 咧就會自己咁樣轉咗出嚟㗎啦。
So that is the video. So the last part of the alarmer, that is the E and the R, is episiotomy and roll over on all fours. The episiotomy is all the things that we know as episiotomy. We will talk about a little bit in the next slide, but it's only to open the diameter here of the soft parts of the mother in order to increase the chances of the baby to go out. The other thing is the roll on all fours, that is the gasking maneuver. That this is the last maneuver, and other people think that it's not very useful, but in this special situation of Bagari District Hospital, it's very useful. Why? Because this maneuver you only can do it when the mother is not under anesthesia. In most of the developed countries, the mother is with anesthesia during the labor, so the mother is not able to put in this position. And this is almost the same than do a McGrover maneuver. So in some situations that you are very far away in a rural area, or maybe you are in Bagari on call in the night alone, and you have this complication, you cannot lift the leg of the mother you alone because you ask for help and anyone comes to help you. You can say the mother that put in this position, and it's almost similar than the McGrover maneuvers. So you put the mother in this position and practice a little of traction and a downward traction of the baby in order to disimpact the anterior shoulder. So now, when do you decide to take an episiotomy? When do you make that decision? Why some mothers have to make, some nurses or some midwife made the episiotomy, some other doesn't made it? What is the thing that can make you take the decision? Well, the important thing here is to know that the decision of taking an episiotomy, you must take it only in the expulsive part of the delivery, because in that moment you will know if the mother needs or not the episiotomy. And which is the thing that give you like the indication of the episiotomy is when you feel that like the soft parts of the pelvis, like the muscles, the skin, or the perineum itself, are restricting the baby to come out, but not the hard parts, not the bones. If the bones are a restriction and you make an episiotomy, you will not help anything because you need to have only a soft parts restriction. Of course, in all of these maneuvers that we have seen, they look very easy in the videos, the rotation of the shoulders and all of that, but it's very difficult because you don't have too much space to put all your complete hand inside. So in that situation also you can perform an episiotomy in order to increase the space to put your hand and rotate the fetus. So the episiotomy depends on your judgment, but you need to take the decision during the second stage, not before and not after, of course. So now, according to the objectives, we have seen the mechanism of a normal delivery and also the shoulder dystocia. Now we will see the emergency that is called the stopped second stage. So we know that second stage is the stage between the 10 centimeters of dilatation and the fetus expulsion. So it's like a shoulder dystocia, but not the shoulder, the head. So it's the head dystocia. It's the moment when the cervix is completely dilated, we're in the conditions for the baby to come out, but the baby doesn't come out. And we don't know why. So how we diagnose this? When the duration of the second stage is more than the normal. So we know that the normal is 1 hour for multipara, 2 hours for premigravida, and we also add that 1 hour more if you are under anesthesia. So which is the treatment for this emergency? The treatment is to provide the ideal conditions for the baby to born and evaluate after 1 hour. So which are the ideal conditions? The rupture of the membranes, if they are not ruptured. Most of the normal deliveries have the rupture of membranes in the 6 or 7 centimeters. So it's very weird to have a mother in 10 centimeters without the membrane rupture. But it's important here to remember because maybe it can happen. So one of the conditions is the rupture of the membranes. The second condition is an adequate uterine dynamic. What is an adequate uterine dynamic? Between 4 and 5 contractions every 10 minutes, with a duration of every contraction between 35 and 45 seconds, and with a complete relaxation between the contractions. If the uterus is completely tonic all the time, it's also a bad thing because the fetus is not receiving blood supply through the placenta. And that means that we give a lot of oxytocin, or maybe we give a lot of misoprostol, or maybe we have a complication, like for example, a ruptured placenta or anything like that. So we need to rule out the subnormal things, that is a little bit contraction, kidoko contraction, that can be like 3 in 10 minutes or 2 in 10 minutes, or maybe a little bit of the duration, like 20 seconds of contraction. Or we also have to rule out a lot of contraction, like 5 in 10 minutes, 6 in 10 minutes, or the duration more than 45 seconds. All of that things, Mingi-Sana contraction also are causes of a stopped second stage, or further and more sophisticated diagnosis like a ruptured placenta. And the third condition important to have with this mother is the mother pushing well. We need the collaboration of the mother. If the mother cannot push because, for example, any cerebral disease, malformation, or maybe detachment of the retina in the eye, or the mother is exhausted, she is not pushing because she is non-conscious or anything, we cannot diagnose stopped second stage because we don't have all the ideal conditions. And we also cannot treat the stopped second stage. So what we need here, we need these three conditions to treat the stopped second stage. And after 1 hour, we're going to know if this stopped second stage, it was because of a CPD, cephalopelvic disproportion, or it was because another thing. Of course, it's very important, this part of the fetal monitorization, because this baby that have a long second stage, it means that it's a baby that is suffering inside and can be suffering because of a placental insufficiency, because of cord around the neck, or anything can happen during this process. So we need to check the fetal heart rate every minute, or check the liquid, if there are meconium or not, all the time, because if one of those things happen, we need to take further actions before and not wait the complete hour. So now, continuing with the treatment, if the mother is on ideal condition, after 1 hour of ideal conditions and the baby has not delivered, it means that we are in a cephalopelvic disproportion. So we need to perform a cesarean section because this baby won't come out, or if the baby come out, maybe can come out with a little bit of complications. If we have the situation that the mother is during the hour, haven't reached the hour, she is on ideal condition, but she is only 30 minutes, but it suddenly appears meconium, or it suddenly appears bradycardia below 110, fetal heart rate below 110, it means that we are in front of a non-reassurement fetal status. We don't know if the fetus is suffering or not, so we need to move this baby out as soon as possible. So we will need emergency cesarean section, or another options that we don't have in Bagari, that is instrumental delivery by vacuum aspiration or by different other tools that we can have, but in Bagari we don't have it. And if the mother is not on ideal conditions, we have recently diagnosed this stopped second stage, we don't have to desperate. We have to provide the ideal conditions and check the fetal heart rate every 30 minutes, or every 10 minutes in order to rule out the non-reassurement. But there are some people that desperate and perform the Christellen maneuver. That is a very important message that I want to give you in this class. That is that this Christellen maneuver is not useful and is almost all the times is dangerous. It's hatari. So please, I want to encourage you to don't perform the Christellen maneuver. But what is the Christellen maneuver? Most of you maybe have been questioning yourself, what is Christellen maneuver? So here I ask you, with this multiple choice answer, please put in pause the video and try to answer this question. The correct answer for this question is fundal uterine pressure. That is the Christellen maneuver. So all of you may be thinking that here in the hospital it's very normal to perform this maneuver, and I know that is normal, I have seen it, but the evidence doesn't say that it's useful and say, of course, the opposite. So please, if you see this, if you see someone pushing the uterus with a lot of strength and all the people desesperated because the baby doesn't born and had been more than 2 hours in the second stage, you need to be calm, you need to assess the fetal well-being, check the fetal heart rate, and if everything is okay, don't hurry up, try to perform the ideal conditions, and then you can check it up. And if there is no ideal conditions, maybe the baby needs a cesarean section, but all of these maneuvers that we do here are harmful for the mother and also for the fetus. Here, in this investigation that was made in Turkey in the year 2014, they separate two different groups, 140 patients in one group and 140 patients in the other group, and they divided. In one group, they performed the Christellen maneuver, the fundal pressure, and in the other group, they didn't perform the Christellen maneuver. And they checked the outcomes, the cervical lacerations, the elongation of the episiotomy, and also fetal outcomes like mortality, attention to NBU, or Apgar of the baby. And they realized that the babies, that the mothers that were randomized in the group that received the Christellen maneuver, they increased the cervical lacerations, they increased the elongation of the episiotomy, and also stronger complications like, for example, uterine rupture. So the Christellen maneuver is not a simple thing. It's not a thing that you can do all the time, and you need to be aware of that. You need to consult all your partners about don't do that, because this can have a lot of different problems for the mother. And maybe most of you can think that this maneuver can help the fetus, can help the baby because you deliver the baby fast and you prevent the perinatal asphyxia. But this study doesn't show anything about mortality or attention to MBU or Apgar that shows better outcomes in the Christelle group. Both of the groups were similar Apgars, similar mortality, and similar attention to MBU. So the Christelle maneuver is not recommended. But like all of the things here in Bagari, we have some situations. And maybe we have some moments that we will need this maneuver because we don't have instrumental delivery, because we don't have vacuum extraction, because maybe we don't have the consultant to help us, and maybe the obstetric surgeon is not here, or maybe there's the theater is not available. So there are some situations that maybe there are no evidence for this, but only because of logic can fit with the Christelle maneuver and can be beneficial this maneuver. So when it is recommended, when you are making an extraction in the cesarean section, all of us know that. In a simple vaginal delivery, if there is no contraindication that we will see, and the fetus is with a fetal heart rate altered. So we're in a non-reassurement, we're in a second stage, and we don't have options to move this mother for cesarean section, we can perform this maneuver in order to make a fast delivery. Maybe the mother is not pushing well, and we need to take the baby out fast because the baby is in a non-reassurement fetal status. So we need to save the baby. But not all the situations are like that. And the other thing that is very important to know is when the head is engaged during a breech delivery. When we have a head retention during a breech delivery, it's recommended to do that maneuver because we're in a desperate situation, and by the evidence is allowed. And which are the contraindications that doesn't allow us to use the Christelle maneuver in these situations are shoulder dystocia. We cannot perform it in a shoulder dystocia because a shoulder dystocia is a space conflict. And it's not a pressure conflict, it's a space conflict. If we increase the pressure, maybe we can break the clavicular bone of the baby, maybe we can increase the tears. So in shoulder dystocia, we use the alarmer. We don't use the fundal pressure. When we have a fundal placenta, also increase the risk of abruptio placenta if we do the fundal height. So this is also a contraindication, so you need to check up the ultrasound of the mother to check out where is the placenta. A previous CS scar, this is a very important complication because increase a lot the risk of uterine rupture. And inadequate dilatation because it means that maybe we are in front of a cephalopelvic disproportion, and if we are in a cephalopelvic disproportion, we cannot provide Christelle maneuver because we will traumatize a lot the fetus. So now we will see the cord prolapse. What is a cord prolapse? Is when the umbilical cord takes position under the fetal head and is compressed against the pelvis. We have two clinical types of cord prolapse. That is the occult cord prolapse that we cannot see and is very high, very up, and the overt cord prolapse that, oh sorry, the video is trapping the image, but is when the cord prolapse is going a little bit in the vaginal channel. So it's very important here the vaginal examination because here to check the overt cord prolapse is very easy. We can look the cord or we can palpate it easily. But the occult cord prolapse, maybe we couldn't be able to diagnose. So it's very important that when we make a VE, to border all the edges of the cervix and try to palpate if we feel something. We have to border all the edges with the finger. And it's also very important not to pull the head baby up, because if we do that, when we do the vaginal examination, we can open this space and the cord can come down. So we also have to prevent the cord prolapse. And how do we prevent it? Without pulling the head out. The clinical manifestation of the cord prolapse is a sustained fetal bradycardia and IUFD. Why? Because the cord is compressed and the blood supply from the placenta to the baby is stopped. We can see the cord visualized or palpated before the fetal head, as I said to you in the vaginal examination. So, which are the principles of the management of the umbilical cord prolapse? The definitive treatment is very important to know. That is the emergency cesarean section. We need to do that before 10 minutes because the baby can die. Okay. The most challenging here is not to decide to do the cesarean section. It's very easy to decide that when we have that diagnosis. The difficulty here, the challenging part, is to diagnose the cord prolapse, because maybe the mother will have any symptom and only the fetal heart rate will come down. So here I want to encourage you or show you the importance of the monitorization during labor, of the monitorization especially during the rupture of membranes, and especially during the VEs, before and after the VE, and also during the second stage, a very strictly and near monitorization of the fetal heart rate and the meconium. But when we are in this situation, we cannot go back. So what do we have to do very fast? We call for help. If we diagnose when we put our hand doing the VE and we diagnose that, we need to pull up the presentation and keep it like that. So we cannot take away our hand from the vagina of the mother. We need continuous fetal monitorization, and also oxygen by face mask can help, like measures of intrauterine resuscitation. So the treatment is immediate delivery, as I said to you, essentially by CS, or maybe it can be instrumental vaginal delivery, but in our setting is not available. And inform the anesthetist, the pediatrician, we have to work fast and as a team. And to do fundic decompression to win time before the cesarean section, what we can do? Elevation of the presenting part with the hand. As I said to you, you have to stay your hand there. Also, the Trendelenburg position or the knee chest position also can help it, because the baby will go a little bit up only because of gravity. The insertion of a Foley catheter and filling the urinary bladder with 500 or 750 ml also can a little bit help with the retraction backward of the head. Now, this image is only to make a little break because this class is very long. And here I show you the city of Santiago. This is my city. Here we have the Los Andes chain mountain that in the winter is very snowed like this. And this is my beautiful city. So now I'm going to talk about uterine inversion. That is almost the last emergency before the podalic delivery. So the uterine inversion is the protrusion of the uterus fundus through the dilated cervix. It's very uncommon, and the principal cause is because of excessive traction of the placenta, or maybe placenta accreta, so the placenta is very attached to the uterus, and when we pull, we can pull the uterus. And what is the problem with this complication is that it can bleed a lot, causing a PPH, a very strong PPH, and hypovolemic shock. And which is the treatment for this maneuver? It's very basic treatment, is to perform the Johnson maneuver. The Johnson maneuver, it's only to pull the uterus back again to the normal position, the reduction of the uterus. And it's very important because if you don't do that, the mother can continue bleeding very fast. Now, the next and last emergency is the podalic delivery. Also, the podalic delivery can be called breech delivery. It's very common, 3.5% of all the deliveries at term, and the risk of this increase if the baby is preterm or if you have an associated pathology like placenta previa, for example, or for example twin pregnancy. Here I show you a multicentric study that is very known, And it's about the breech delivery. This study shows that the breech deliveries, if you make it in a simple vaginal delivery, the breech delivery have more perinatal mortality, neonatal mortality, and serious neonatal morbidity, like perinatal asphyxia. So the risk was significantly lower when you plan a cesarean section for this group of patients in order to prevent this complication. And which was the principal complication here? The retention of the head. In the last moment of the delivery, the retention of the head. So here I ask you a question. You're in the hospital Bagadi attending a patient that comes in labor. She has no antenatal care, neither an scan. The fundal height shows you that she's on term and the fetal heart rate is normal. You perform a VE that shows 10 centimeters dilatation and you palpated breech presentation. What do you have to do? So I encourage you to think a little bit about this and then we will show you the answer. The correct answer is the letter B, to communicate the doctor and try to perform a cesarean section, an emergency cesarean section, as soon as possible, if it can be. Prepare for podalic, and if it can be. But you have to be prepared for podalic delivery because maybe you won't have the time to do that. And also to prepare the neonatal reanimation team because this baby have more risk to born depressed. Breech delivery treatment. So the treatment, as I showed to you, always is recommended the cesarean section. That is the important concept. It doesn't matter where you are, if you're in the rural area or where you are, it's recommended the cesarean section. Okay? If the patient is complete dilatation, and there is an imminent delivery, the person attending the delivery must don't do anything. There are a lot of different maneuvers, but the most recommended here is not to do anything and wait for the baby to come out slowly. Because if you try to rotate the fetus, maybe you don't have experience, this is not normal, and it's not recommended. In the case that you have the possibility to make a cesarean section, you have to run very fast. But maybe there are some situations that you can be with the mother 10 centimeters dilated and you're in a rural area and the nearest hospital is at 4 hours away. You cannot perform a cesarean section, so you need to wait, as I say to you here. And in the case of head retention at the end of the delivery, you must perform an emergency cesarean section. And if you cannot do it, well, you have to try to do Christelle maneuver and try to do whatever you want, but this is the most terrible complication. There is a specific maneuver from the breech delivery maneuver that is called the Mauricio maneuver. That is to flex the baby upwards until you reach the back of the baby to the pubic symphysis. This increases the chance of getting away the baby. And also you can fix the neck of the baby, putting your hand in the mouth of the baby. But this maneuver, you have to practice this at the end of the breech delivery. You don't have to do anything before the delivery of all the body of the fetus. So now we have seen all the emergencies during labor that we have proposed to learn. I hope you like this presentation, and I invite you to watch all the rest of the videos of the in-hospital seminars. The little golden potatoes of this video, the most important thing here is that you need to know that the importance here is to recognize these emergencies. We need to be able to recognize they are not so frequent, so please, I need you to memorize all of the things of these videos and all of this class. And the key here is preventing and be prepared. There are some situations that we cannot prevent, but also there are another that we can prevent. For example, we can prevent the cord prolapse, performing a rupture of membranes only when the head is engaged. If we perform the rupture of membrane when the head is floating, we have more risk of produce a cord prolapse. Also, we have to prevent all the things associated with macrosomy because that is associated with the stop and second stage and with the shoulder retention. And always prefer the cesarean section for the podalic deliveries. And we need to say that to the mother in the antenatal care. When the mother is 38 weeks, she's at term, and the presentation you feel in Leopold that is breech, you need to say to the mother because she needs to plan for a cesarean section. If the mother lives in a rural area very far away, you need to encourage the mother to go to a healthcare center, to a biggest hospital, to maybe to a city, because this delivery cannot be by a simple vaginal delivery. And always have in mind the cord prolapse, because it's a thing that is very difficult to diagnose, it's very challenging. But if we are able to diagnose this, we can act fast and solve this problem and save a life. Thank you very much. Now we have finished our presentation. Please, if you have any doubt, you can watch the video all the times that you want, at the velocity that you want. But also you can send me a WhatsApp or an email, and I happily can search with you the results of your questions. Thank you very much.